So, good evening, all of you, and another fine evening tutorials, second one of its kind on pediatric neurology topics. And this time, the first three are leukodystrophies, inborn errors of metabolism, and the last one, obviously, we cannot miss neurocutaneous syndromes. So I have included one of them. I thought tuberous sclerosis was important. It was the one that had appeared most frequently. And as you can see, the neurometabolic, or we would call inborn errors of metabolism. And these again were the ones that I saw have appeared at least twice. First of all, and another point is that I thought approach to leukodystrophies was very important, both as a theory question, the way it has appeared in the exam, as well as occasionally if there is a patient in the ward at that point of time, certainly it would be chosen by examiners as a case. So both ways it was useful, and so was Fabry. So that was the reason I chose. Although there are a lot more areas that would need covering, which I hope through the lectures that you will be hearing in the next hour or so, you would learn how to prepare for more of such questions. With that, I'll begin with my first session, which is the spectrum of leukodystrophies in children, which will be delivered by Dr. Prabjot Kaur. So I request her to begin her session. Prabjot.
Thank you, Dr. Pujari. So I think, yeah. So very good evening, everybody. And at the outset, I would like to thank Fine Forum for letting me a part of this symposium. So my brief has been to talk about the spectrum of pediatric leukodystrophies. As a as a trainee, would like to write a question and answer. So I've tried to cover as much as of it is possible, but it is a huge topic, and I hope that I have done some justice to it. So what I'll be talking about is about what are the common leukodystrophies in childhood, what are the presentation and the clinical pointers, what investigations we need, and how do we approach to the diagnosis, and what are the treatment modalities, if at all available, for few of these disorders. So white matter disorders, when we talk about these, so basically they can be demyelination, which is the destruction of normal myelin. They can be hypomyelination, in which there is a disturbance of normal myelin formation. Sometimes they can be even delayed myelination, in which the myelination is not progressing as per age as we expect it to be. And then there is an entity with dysmyelination, in which there is a formation of abnormal myelin. So what we are going to discuss today is basically these two disorders, which is dysmyelination and hypomyelination. So by definition, leukodystrophies are inheritable disorders affecting the white matter of the CNS with or without the peripheral nervous system. So basically, they are glial cell or myelin sheath abnormalities with the involvement of oligodendrocytes, astrocytes, and other non-glial cell types, non-neuronal cell types, and they have a hugely progressive course. So if we look at the classification, the broad classification, it is according to which is the major cellular organelle involved, like lysosomal storage disorders, peroxisomal disorders, mitochondrial disorders, amino acidopathies, or other organic acid metabolic disorders, and some disorders in which the exact organelle involved is not known. So how do these disorders present in children? So they either present with regression with white matter signs. Sometimes they'll have an acute regression in a previously normal child following a trivial trauma or a febrile illness. Sometimes they can have just a baseline developmental delay along with presence of white matter signs. Occasionally, the child may have a baseline developmental delay, and after that, the rate of milestone attainment may be very, very slow. So all these things are how these children will present. And the classical white matter signs, as we all know, are spasticity, optic atrophy, hearing issues, presence of peripheral nervous system involvement, and sometimes ataxia. So there are a few clinical pointers for these disorders, like dysmorphism with coarse facies can be seen in gangliosidosis, mucopolysaccharidosis. Persistent large Mongolian spots can be seen in GM1 gangliosidosis, Hunter's disorder, Niemann-Pick type C, and mannosidosis. Hyperpigmentation of the body along with hypoaldosteronism can be seen in X-linked ALE. Angiokeratomas are a feature of Fabry's, fucosidosis, sialidosis type 2. Dysostosis multiplex is seen in gangliosidosis. Excessive irritability and startle is something that we classically see in Krabbe's. Excessive startle can also be seen in Tay-Sachs disorder. Hepatosplenomegaly can be seen in GM1 and Niemann-Pick disorder. Cataracts can be seen in galactosemia, retinitis pigmentosa in mitochondrial disorders, cherry red spots in GM1, GM2, Niemann-Pick type C, and peripheral neuropathy can be seen in late infantile MLD, Krabbe's, and sialidosis. So how do we approach these disorders? So clinically, as we have seen, they will present with a regression and white matter signs. We look for extra CNS features like presence of hepatosplenomegaly, presence of eye abnormalities, hearing abnormalities, peripheral neuropathy. We look at the head circumference. So is the head circumference normal for age? Is there microcephaly? Is there macrocephaly? And then we look at the specific clinical pointers. Now the main imaging, the main investigation that we want to do is MRI brain. Usually with contrast, if required, if we clinically suspect, we can also do MRS and we can also do spine MRI. Ancillary testing to look for additional organ involvement like VP, BERA, fundus, it is required, gives us additional information as to what may be the underlying diagnosis. And confirmatory testing is either enzyme testing, and finally what we usually do these days, it is genetic testing. So the major approach for these disorders after the clinical pointers is MRI-based pattern recognition approach, which is the most important. So if we look at the pattern recognition approach for these disorders, so the involvement of the white matter can be deep white matter involvement, subcortical, diffuse cerebral involvement, and involvement of cerebellum or the middle cerebellar peduncles. So deep white matter involvement can again be frontal predominant, parieto-occipital predominant, or periventricular predominant. So frontal predominant kind of leukodystrophy we see in Alexander's and MLD. Parieto-occipital predominant we see in ALD, Krabbe's. Periventricular we see in MLD, which is metachromatic leukodystrophy, Krabbe's disorder, and Sjogren-Larsen syndrome. Subcortical involvement classically is seen in Canavan's disease and sometimes in L2 hydroxyglutaric acidurias, Kearns-Sayre syndrome. Diffuse cerebral involvement can be seen in end stages of almost all leukodystrophies. Other disorders include metachromatic leukoencephalopathy with subcortical cysts, vanishing white matter disease, or childhood ataxia with central hypomyelination. Predominant cerebellar involvement can be seen in cerebrotendinous xanthomatosis, Alexander disease. Even dentate involvement we can also see in Krabbe's. So if we look at deep white matter involvement with leukodystrophies, then we look at what are the other structures involved. So is the thalamus normal? Is the brainstem involved? Is the basal ganglia normal? So if we look at the disorders in which the thalamus and brainstem are normal and deep white matter is involved, we can have further certain types. So we see a tigroid pattern in case of metachromatic leukodystrophy. We see volume loss with cystic changes and sparing of the corpus callosum in vanishing white matter disorder, disorder. Posterior predominant leukodystrophy with prominent contrast enhancement we see in X-linked adrenoleukodystrophy. Krabbe's disease again can have a posterior predominance, but it typically involves the tract. So we are able to trace the tracts from the centrum semiovale down through the internal capsule and the brainstem. Sometimes it can also have optic nerve hypertrophy and thalamic hypodensities. Phenylketonuria, we can see periventricular deep white matter involvement with phenylalanine peak on MRS, and frontal dominant leukodystrophy with contrast enhancement is seen in Alexander's disease. So this is an MRI image which is showing MLD. We see that this kind of radiating kind of pattern we see from the periventricular to the peripheral area. So this is something that we typically see in metachromatic leukodystrophy. X-linked ALD, we have posterior dominant periventricular involvement with this advancing kind of edge, which we can see as hyperintensity on the FLAIR images. Splenium of the corpus callosum is one of the earliest structures to be involved with ALD. And if we have contrast images for these patients, it will show contrast enhancement along these areas which are showing hyperintensity on the T2 or FLAIR images. Vanishing white matter disorder, the CT is, in this image, the CT is showing diffuse white matter hypodensity. And the MRI shows involvement of the periventricular white matter. And the cystic changes again, which we see here in the deep white matter, they start in the periventricular region and they then progress to the peripheral regions. Krabbe's disorder, the second image, we can see that you can actually trace the tract involvement from the white matter above down through the internal capsule. And if we have further images, you will also see that early dentate involvement can also be seen in Krabbe's. Phenylketonuria, again, deep white matter involvement along with phenylalanine peak on the MRS. So other disorders with the periventricular white matter involvement with involvement of thalamus can be seen in gangliosidosis, in which there is predominant thalamic and basal ganglia involvement with corpus callosum sparing. Brainstem and cerebellar involvement we can see in early onset disorders like MSUD, in which there will be prominent brainstem involvement, can have a broad peak of branch ketose chain acids at 0.9 ppm. And in Addison's disease, we can see brainstem involvement, tract involvement, along with which is basically the adrenomyeloneuropathy pattern. So this is another disorder, which is Sjogren-Larsen syndrome. Although the MRI picture again is that of a deep white matter involvement, but clinically it has got a very typical picture in which the children present with congenital ichthyosis, have subnormal intelligence, and have progressive spastic tetraplegia. So there's impaired fatty acid aldehyde dehydrogenase activity. And what we see in the MRI is deep periventricular white matter involvement and a lipid peak, which is very prominent in cases of Sjogren-Larsen syndromes. So this is the ichthyosis, which is very prominent in these kids. So coming from deep white matter to subcortical white matter involvement, in subcortical white matter involvement, we again have two groups of disorders. So there's one group which presents with macrocephaly. So with macrocephaly and subcortical cysts, we have a disorder, the leukoencephalopathy, known as megalencephalic leukoencephalopathy with subcortical cysts, with presence of subcortical white matter involvement, presence of GP hyperintensity on T2 images, and a prominent NAA peak is seen in Canavan's disorder. Without macrocephaly, subcortical involvement with basal ganglia calcifications and lactate peak, we see in KSS. There are other clinical pointers, obviously, for KSS, which you will be able to see clinically. So if you look at the imaging, so this is a child who had MLC. So if you look at the T2 images, we can see that anteriorly there is cyst formation in the temporal poles, which again we can also see in the T1 images. In this image, we can see that in the T1 images, the subcortical white matter has started rarefying. So subcortical cyst formation is already there. In case of Canavan's disorder, there is a prominent white matter involvement. This is a progressed case of Canavan's. Early onset, they will have subcortical involvement and prominent GP hyperintensities and a NAA peak on the MRS. So moving on from the major leukodystrophies, we move on to hypomyelinating disorders. So what happens in hypomyelination is that there is severely deficient myelin formation. So if we look at the MRI of these kids, the T1 appears actually iso-intense or near normal. Occasionally it can be hypo-intense in case there is a severe hypomyelination, and T2 is hyperintense. So we have an MRI picture in which the T2 images look very abnormal and the T1 images look relatively okay. Generally there is a diffuse involvement, and the MRI tends to look like the normal MRI of a very newborn or a very young child. So at this point, I would like to make a statement that the myelination progresses from the time the child is born as the child grows up. So at the time of birth, only the posterior limb of the internal capsule, the perizolandic areas, and the brainstem is myelinated. And as the child grows on, the different areas progresses the myelination progresses in different areas. So in cases with delayed myelination, the myelination is not progressing as per the we are expecting for the age. For these cases, we should repeat a scan after 6 months and see if the myelination is progressing or not. Versus hypomyelination, in which the myelination does not occur. So there is a severe myelination defect in these kids. So there are a few clinical pointers for hypomyelination also, like presence of nystagmus and spasmus mutans we see in Pelizaeus-Merck-Packard disease. Presence of cataracts with hypomyelination we see in hypomyelination with congenital cataract. Presence of dental abnormalities or delayed dentation with hypogonadism we see 4H syndrome. Photosensitivity we can see in Cockayne syndrome, and dysmorphism is generally seen in 18q deletion syndromes. So again, if you look at the MRI pictures, so Pelizaeus-Merck-Packard disease has a homogeneously T2 hyperintense. So there's a diffuse involvement of the cerebral white matter. Only the optic tracts are the one areas which are which are myelinated. In PMLD, which is Pelizaeus-Merck-Packard like disease, they have associated pontine T2 hyperintensity. Now, this is not an absolute differentiation. We also have brainstem involvement in case of PMD, but the pattern of PMD and PMLD can be a little different from each other. In hypomyelination with congenital cataracts, there is sparing of the subcortical white matter and the deep white matter is involved. And as the name suggests, that there are cataracts. Early cerebellar atrophy with hypomyelination, we see in syndrome known as 4H syndrome, which is hypodontia, hypomyelination, and hypogonadotrophic hypogonadism. Hypomyelination with significant basal ganglia atrophy we see in HAPC, which is hypomyelination with basal ganglia atrophy. And in fucosidosis, we have basal ganglia hypointensity with hypomyelination. So basically basal ganglia involvement along with hypomyelination. We'll have a look at few of these images. So this is an image of a child with Pelizaeus-Merck-Packer disease. Now, if you look at the T1 image, it looks fairly normal. It doesn't look like it is, there's a lot of abnormality going on here. But if you look at the T2 images, the white matter is diffusely hyperintense. And if you look at the posterior limb of internal capsule, it is also appearing white. So the myelination of even the posterior limb of the internal capsule has not happened. And if we look at the optic tracts here, the myelination here is preserved. So this is something that we see in PMD. So this case, this was a 5-year-old girl who had presented with ataxia, dysarthria, and intention tremors. So for a 5-year-old girl, even the dentition is very much delayed. The central incisors are not there. Again, if you look at the T1 images, they look pretty okay. Like you don't see a lot of abnormality. But if you look at the T2 images, again, even in the T1 images, we are seeing that for a 5-year-old girl, the myelination is not that appropriate as it should be. Only the central white matter looks like it is properly myelinated. And the T2 again, if you look the entire T2 white in the entire in the T2 images, the white matter looks fairly hyperintense with lack of myelination. Again, the internal capsule is non-myelinated. So this is a typical image of a 4H syndrome. This image is of a 5-year-old boy who had presented with regression at 10 months after a trivial fall with epilepsy and bilateral zonular cataracts and UMN signs. Again, we can see that although the T2 is not completely normal, it also has it does have some deep white, deep periventricular hypointensities, but doesn't look that bad. Again, T2 is really showing white matter hyperintensities in the entire white matter. So this child had hypomyelination with congenital cataracts. So this is the last case. This was a 4-year-old boy had presented with gradual regression at 18 months with mild coarse facies and no organomegaly. What is very prominent here is that on the T1 images, we can see that the globus pallidus is hyper intense. And on the T2 FLAIR images, we can see that there is a hypointensity of the GP. And the white matter again looks abnormal. It is not myelinated. So this child was diagnosed as having fucosidosis. So there are a few other special MRI features for kids with leukodystrophy or hypomyelination. So anterior temporal cysts, we do see in Megalen-Keflik leukoencephalopathy with subcortical cysts. Cystic white matter degeneration, we see in vanishing white matter disorder, mitochondrial cytopathies, Alexander disease. Megalen-Keflik leukodystrophies, which is with a large head size. We have Alexander's disease, Canavan's disease, and MLC. Contrast enhancement, typically we see in X-linked ALD and Alexander's disease. Calcium deposits we can see in Aicardi-Goutieres disease and cocaine disorder. So once on the basis of the clinical findings and the MRI, we will have some differentials on the basis of MRI patterns. And for confirmation, we will require enzyme testing and genetic testing for these kids. And wherever possible, we should always try to get a genetic confirmation for possible treatment implications, maybe now or in the future, and also for the future family implications, because many of these disorders will be autosomal recessive. So we need to give the family a genetic diagnosis so that they can have an antenatal diagnostic plan in place for the future pregnancies. Just to touch upon the treatment options. So the treatment options are very, very limited at this point of time. The predominant stay of treatment is symptomatic management. Dietary modifications may be helpful in a few disorders like phenylketonuria, galactosemia. Hematopoietic stem cell transplantation has been tried for a few pre-symptomatic and early symptomatic cases, especially for ALD and Krabbe's. Now it is being tried. Other disorders where HSCT may be tried are MLD and Canavans. So with this, I will finish my talk. So it is actually a very exhaustive topic, and I have just managed to cover a few of the disorders. Thank you.
Still, I think, Dr. Kaur, in this short span of time, superb. You have managed to really cover everything and give a very nice approach with initial dysmyelinating, hypomyelinating, and then going according to the metabolic pathway, and then with large head, and then going on slowly with MRI and other associated features. I suppose that's exactly how the approach has to be. Superb. I think
Yeah.
I loved the lecture. Really nice. Thank you.
Thank
Thank
you.
you very much. Let's take the second topic, which is NBIA, another favorite amongst examiners. I see it. So I request Dr. Lingappa to deliver his talk on this important topic.
Thank you. I thank the fine team for inviting us. Dr. The first talk was pretty good by Prabjot. We'll try to keep to time. Neurodegeneration with brain iron accumulation is a challenging condition for the parents and the physicians as such. So, although it is for a theory paper, but I think practically also it is important to know when to suspect them. We'll go through the introduction, genetic types, pathogenesis, brief phenotypic description, clinic and imaging approach. As in leukodystrophies, imaging plays a very important role in identifying this group of disorders and narrowing the differential diagnosis. They are all genetic in origin. They have very heterogeneous interaction. There can be inter and intra subtype variations. The same gene can have varied phenotypes. So we need to be aware of those things. So main entry point here is iron accumulation in the basal ganglia complex plus or minus other structures. So it's extremely rare. 1 to 3 per 10 lakh population is the incidence of this disease. And they manifest predominantly with progressive extrapyramidal symptoms. Dystonia, Parkinsonism, chorea, all forms of more extrapyramidal symptoms can be seen. At times with pyramidal signs, cognitive dysfunction or ocular abnormalities. So when you suspect clinically with this complex, correlate radiologically with the iron deposition and then confirm genetically to narrow down the phenotype. So the spectrum is wide, but the commonest one is PCAN, which constitutes 50% of the disease, followed by infantile neuroaxonal dystrophy or PLAN, or AMPAN is 10%. So all these three things put together constitute 80%. Other things are not so common. So pantothenic, so OMIM, there are 10 subtypes described under the NBIA under Edling, and if you just a minute. Yeah. So PCAN is the most common, accounting for 50% of these children, pantothenic kinase associated neurodegeneration. So after this is the earliest presentation as well. Then you have phospholipase A2 associated neurodegeneration, which is secondary to PLA2 G6, and membrane protein mitochondrial membrane protein associated neurodegeneration. So all these three are autosomal recessive. There is only one X-linked dominant disease, that is WDR45, and then one autosomal dominant disease, that is neuroferritinopathy. So these are the common conditions what we come across. Iron accumulation, whether it's causal or secondary to neurodegeneration, it's still not clear. The hypothesized iron accumulation are secondary to mitochondrial dysfunction, and in some disorders like PANC2 and PLA2G6, cell degeneration mediated through reactive oxygen species is known to be the etiology for iron deposition, whereas altered lipid metabolism is the reason in PANC2, PLA2G6, FA2H, and mitochondrial membrane protein related disease. Whereas altered mitophagy and autophagy is in WDR45 and ATP13A2. So dysfunction in proteins related to iron metabolism, which include aceruloplasmia and neuroferritinopathy. So these are the various pathogenesis identified for the iron deposition. Although the ultimate problem seen on the imaging is iron deposition, but the etiology for that, how the iron reaches the basal ganglia complex, they're quite different. So there is a detailed genes coding and their mechanism. I'm not going to go through the details of this. This has been well written in a recent paper in Annals of Indian Academy of Neurology in 2019. So this reference will be shared with you. So PCAN is the first NBA to be described. Earlier we used to call this as Haliburton-Spatz, as I don't know, it is in the earlier terminologies, textbooks, this term was used because during the Nazi executions, the people with low intellectual capacities, they were studied by Haliburton and Spatz, and then the condition was published initially. Because the way that research was done, it was found to be unethical, and then that's why the name was removed and it has been replaced by NBIA-1 or PCAN. And this is the most common NBIA what we see in the clinical practice, and they have heterogeneous phenotypes. The classic one is more severe, early onset, and more of dystonia. Atypical variants are less severe, later onset, and more of Parkinsonism. Usual presentation in the typical one is first decade, present with gait or postural difficulties. So they can start with dystonia, and it can be with just one limb dystonia or craniofacial dystonias, then progress to axial dystonia. This is one of the most disabling condition you can see, because none of the medications do actually change the natural outcome of this disease. They can have severe opistotonic posturing and mantis sign, which we'll show in the imaging later on. Atypical manifestation is usually onset in second and third decade, less severe dystonia, and slowly progress to Parkinsonism. They have four phenotypes. One is dystonic, which can be focal, going on to generalized. Second one is Parkinsonism, young onset Parkinsonism. We can think of this if you have a brain iron accumulation. Isolated drug responsive bradykinesia, tics or chorea is another presentation, followed by HARP syndrome, where you can have hypobeta-lipoproteinemia, acanthosis, retinitis pigmentosa, and pallidal degeneration. So same gene, depending on the residual genetic material available, you have different manifestations. So this is what is called a praying mantis sign. This is they are trying to reduce their dystonia by touching the chin. So in that way, they'll try to reduce the amount of arching which happens. And you can see this almost, they become like a banana, complete arching of the axial muscles. It's extremely challenging. To feed them itself is extremely challenging, say, severe oromandibular dystonias. So quite disabling for the family members and the people involved, because they have a very long course of the illness, and that causes a significant morbidity in this group of children. NBIA2 or PLAN, which is a continuum, they have three age distinct overlapping phenotypes, and it's reasonably commonly seen. The classic type what we see is infantile neuroaxonal dystrophy, and atypical one is called Carrack syndrome, and adult onset is dystonia Parkinsonism syndrome. And 85% of PLAN present as infantile neuroaxonal dystrophy. It is once again a very devastating syndrome of neurodevelopmental regression with onset between 6 months to 2 years. They are characterized by axial hypotonia as presentation. And this is usually a unique presentation of among all the other NBAs. They have neuroregression, gait abnormality, nystagmus, strabismus, and optic atrophy with progressive pyramidal and bulbar involvement. Dystrophic axons are found on nerve biopsy, hence the name, although you don't need nerve biopsy to establish this diagnosis today. I'll not go into the details. So onset is usually in the early infancy, and then usually most of them die by around 5 to 6 years of age, such a rapid progression course. Atypical neuroaxonal dystrophy, slightly later onset, mostly present with gait instability in the form of ataxia, dyspraxia, speech regression, and optic atrophy in 2/3 of cases. They progress to spastic tetraparesis, nystagmus, and seizures are also seen. Whereas Carrack syndrome is secondary to homozygous mutations in PLA2G6, and this is grouped under NBIA2B. The adult onset PLAN is adult either in adolescent or adult onset. They present with subacute onset levodopa responsive focal dystonias, either in the form of foot dystonias or blepharospasm. Parkinsonism in the form of rigidity and bradykinesia is seen in majority of them, which are levodopa responsive in the initial part of the illness. Cognitive decline slowly, and oculomotor abnormalities in the form of supranuclear gaze palsy is also seen. And cerebellar symptoms and signs are generally absent, even though you might find there is a cerebellar atrophy on the neuroimaging. And autonomic dysfunction is unique to this presentation. The third group is neuroferritinopathies, which is the only autosomal dominant form of NBIA. Mutation in ferritin light chain is the etiology, usually midlife onset. They present with dementia. Frontal executive dysfunction is seen with psychiatric symptoms along with slowly progressive movement disorder. And striking asymmetry. Generally, we think of most of the inherited disorders are symmetric in onset, but here the striking asymmetry is the hallmark. The triad of oromandibular dyskinesias, dysarthrophonia, and action-specific facial dystonias usually are classical for this condition, along with other abnormalities of oculomotor problems, sleep disturbances, and abnormalities in the vibration and proprioception loss. And they have classically low serum ferritin. Whereas MPAN is membrane propeller associated neurodegeneration, and mean age of onset is around 11 years. They are also characterized by gait and speech abnormalities, focus dystonias, almost similar to PCAN, but progressive spastic paraplegia and a Parkinsonian feature, which is unresponsive to L-DOPA. Optic atrophy is seen in a large percentage of these children, and progressive muscle atrophy is a later manifestation of the disease. BPAN or SENDA is a very unusual presentation in the sense they have a biphasic disease course. We had a child who presented at 14 years of age with global delay. Predominantly, the child had cognitive issues, but very well preserved gait and had sleep disturbances and some hand stereotypies. Later on, she presented to us around 21 years of age with slowly progressive Parkinsonism, repeated falls, and she was responsive to levodopa, and she is now 25 years, still is able to walk. She has significant Parkinsonian features, and now the response to levodopa is gradually reducing. Apart from that, they can have characteristic dance-like movements of extremities with onset in sleep. Hypersomnolence is other feature of this condition, which is not seen in other conditions. Other unusual conditions, uncommon conditions, I'm not going to go into details. Aceruloplasmia is onset usually in 4th to 5th decade. Iron accumulates in multiple areas, causing retinal degeneration, diabetes mellitus, and neurological symptoms and signs. And usually later onset, they have neurological manifestations like cerebellar dysfunction, hyperkinetic movement disorder, and Parkinsonism. Cognitive dysfunction is seen in around 60% in the form of apathy and memory impairment. So you have a combination of low serum iron, elevated ferritin, hepatic iron deposition, along with low or absent ceruloplasmin is the key finding to identify this condition. FAHN, which is fatty acid to hydroxylase associated neurodegeneration, is similar to infantile plan, usually can have first decade onset, but they are slowly progressive in nature with prominent ophthalmoplegic features, along with sparing of intellect until late into the illness. Kuffar-Rakib syndrome is extremely rare condition. I had opportunity to discuss this with Professor Uday Mutane. Onset in second decade, juvenile onset Parkinsonism. Parkinsonism is initially responsive to levodopa, later on develop disabling dyskinesias and hallucinations. They also develop oculogeric dystonic spasms. Dystonia develops almost in 50% of cases which are refractory to therapy. And Woodhouse-Sakati syndrome is another rare condition. The identification is used usually by neuroendocrine disorder and dysmorphism, which are along with keratoconus and syndactyly of hands and feet. Also have hypogonadism and diabetes mellitus. So stepwise approach, age at onset, typical clinical features. If you have retinopathy, PCAN. If you have optic atrophy, PLAN, FAHN, and MPAN. Neuropathy is seen in PLAN and MPAN, and brainstem atrophy in FAHN and KRS. So I'll not go through these things in detail because they will be there in the text for you. We'll just go through the approach on the table. That will be better for us with some examples. So PCAN, eye of tiger sign, is because of cystic changes within the ventral part of basal ganglia. This is the iron deposition which is giving you hypointensity, and the cystic change there gives the eye of tiger sign in PCAN. Whereas in neuroferritinopathy, you have patchy hypointensity within the multiple deep gray nuclei. So you have multiple areas of hypointensities along with, you can see this hypointensities in multiple areas as compared to only GP here, and concurrent T2 hyperintensities within the regions of hypointensity, that is the cavitations. It is more extensive in neuroferritinopathy. Whereas in PLAN, the classic features are cerebellar atrophy and clival hypertrophy here, along with evidence of basal, the iron deposition, which is seen. So that is PLAN. Aceruloplasma, you have widespread brain iron deposition with white matter hyperintensities, extensive white matter hyperintensities, and widespread iron deposition. So that's your clue. Whereas in FAN, there is a confluent white matter abnormalities which is seen, and iron deposition in the GP and significant pontocerebellar atrophy. We can see this very severe pontocerebellar atrophy is seen. So that is a clue for FAN. And SENDA-RBPAN, you have predominant hypointensity of globus pallidus as in PCAN, but you can see here the hyperintensities in the substantia nigra and cerebral peduncles with central hypointensity, and global cerebral atrophy in the later stages is a feature. So this is additional clue along with the clinical history of two biphasic illness. So if you quickly go through the clinical radiological approach, so if you have MRI evidence of iron deposition in globus pallidus, look for T2 white matter hyperintensities. If it is there associated with cerebellar atrophy and claval hypertrophy, you are looking at infantile neuroaxonal dystrophy. If you are having globus pallidus iron deposition, eye of tiger sign with pigmentary retinopathy, the commonest finding is PCAN. Whereas you have, along with this substantia nigra hyperintensity, it is SENDA, biphasic course. Whereas along with white matter hyperintensities, you have alopecia, endocrine dysfunction, you know it is WSS, wherein you have multi-organ dysfunction. If you have T2 hypointensities along with GP, caudate, putamen, and thalamus, you have multiple differential diagnosis. So one is aceruloplasmia, if you have decreased copper and ceruloplasmin, and Kupffer-Racab syndrome, if you have mini polymyoclonus and diffuse cerebral atrophy, and NFT, if there is a patchy involvement of basal ganglia, hyperintensity with the cavitation. So I think clinically on a day-to-day basis, the first one, INAD, PCAN, SENDA, aceruloplasmia. These are the four common things which you see, and probably you need to remember, occasionally we see the FAN as well in the clinical practice. Rest of them are extremely rare. Management is multidisciplinary in nature. Genetic diagnosis need to be attended for antenatal counselings and also the prognostication. And drugs for dystonia are hardly of any benefit. Levodopa trial has to be done in cases because some patients are responsive to this. Iron chelation, although is a attractive option, but it is of no clinical benefit. Deep brain stimulation of bilateral GP has been shown to have some benefit in some cases, but not usually in large number of patients. Thank you.
Again, thank you, Dr. Lingappa. Such a thorough lecture within a short period and with very few slides. You managed to cover everything right from classification to pathogenesis and then the MRI findings, the salient features of each of them, very important because through which we can differentiate an MRI. So excellent. I think this was very nice, very useful for the PGs. We'll move on to the next. Before that, just a reminder, on Thursday, Dr. Rakesh Singh is going to take your class on assessment of memory and frontal lobe functions. So please take benefit of the same. And with that, we start our third lecture, which is on Fabry's, another one on the metabolic disorders by Dr. Saini. So I request Dr. Saini to enlighten us.
Good evening, sir. Sir, am I audible?
Yes, you are.
Good evening, everyone. thank you. I thank the FINE group for giving us the opportunity to discuss these interesting topics here with a very specific objective. So the topic that I have been allotted is clinical features, genetics, and treatment of Fabry's disease. This is also known as Fabry-Anderson disease. And just as a part of trivia, Dr. Fabry was a dermatologist while Dr. Anderson was a surgeon, and both of them simultaneously in different parts of the world discovered the phenotype at the same time. Now, since these sessions have a very specific objective of being useful to the PGs, so I have to reiterate that there are some things which we'll try to remember so that we are able to understand the others. So for understanding Fabry's disease, I would like everyone to acquaint themselves with these three terms. So we'll be using GLA gene, which is the gene for Fabry's disease. There'll be one enzyme, alpha galactosidase A, which we'll refer as alpha gal. And then there is a product of there's a product which will be used again, which is globotriaosylceramide, which will be referred as GB3 or GL3. So when you read literature about Fabry's, these are the three terms which we need to remember: the gene, the enzyme, and the sphingolipid in question, which gets accumulated in Fabry's disease. Now, so we'll be covering the definition or the introduction to the topic, clinical features, a quick look at the genetics, what are the treatment options, and what is the ongoing research. So Fabry disease or Fabry-Anderson Fabry disease is a multisystemic inborn error of metabolism. It is a type of a lysosomal storage disorder with X-linked inheritance. The cause is decreased activity of alpha-gal A enzyme, and the result is the lysosomal accumulation of neutral glycosphingolipids, which is GL3 or GB3. So this is a simple diagram which you can use in your exams as well. So if GB3 is this compound, which is composed of ceramide, galactose, and glucose chains, then in the absence of alpha-gal enzyme in Fabry's disease, this breaking down of GB3 does not occur. So as a result, there's a lysosomal accumulation of GB3. So this is the basis of the etiopathogenesis, that the faulty gene is GLA gene on the X chromosome. The enzyme which is deficient is alpha galactosidase A. It breaks GB3 into galactose and lactosylceramide. When this does not happen, there is lysosomal accumulation of the neutral glycosphingolipid GB3 or GL3. Because of this progressive accumulation, there is swelling and proliferation of the endothelial cells, which results in vascular manifestations such as occlusion, ischemia, and infarction in several organs. And this GB3 accumulation is also associated with cytotoxic, pro-inflammatory, and pro-fibrotic effects. So the prevalence of Fabry disease is estimated in males to be 1 in 17,000 to 1 in 1,17,000. And it is a pan-ethnic disorder and seen in all races. There are predominantly two clinical forms: an early onset or the classic form, which results when the enzyme activity is less than 3%. There's a late onset form when the residual enzyme activity is between 3 to 30%, and more than 30% is considered as normal. The late onset form sometimes only manifests as a cardiac disorder, whereas the early or the classical onset forms present as a multisystem disorder. So this is something which we need to remember. The clinical manifestations are several. There are some manifestations which begin during childhood, teenage. There are some manifestations which start appearing in the second decade. And by the third decade, there is evidence of organ dysfunction. So in the childhood or teenage, the classic symptoms are a neuropathic pain associated with dyshydrosis, which can be hypo or hyperhidrosis. When there is hypohidrosis, it is associated with several episodes of fever. There can be ophthalmological involvement in form of cornea verticillata or tortuous retinal vessels. There can be hearing loss. The classic manifestation, which is very specific for Fabry's disease, is the angiokeratoma. And these are typically seen in the palms, along the umbilicus, at the mucocutaneous junction of the lips, and on the back. The other manifestations are microalbuminuria and GI symptoms. By the second decade, major organs start getting affected, such as the heart and the brain, as well as the kidneys. And by third decade, as we said, there is evidence of organ failure. Now, this is a small mnemonic which I've tried to make for Fabry's disease so that it is easy for you to remember the manifestations. So F can denote the presence of foam cells in the glomeruli, which means the disease manifestations in the kidneys, as well as febrile episodes. A for angiokeratomas and anhidrosis. B for burning pain in the extremities. R for renal disease and ringing in the ear, which can initially present as tinnitus and can worsen to a hearing loss. The Y you can remember for the XY phenotype, which means the disease is X-linked, and I, you can also remember the I manifestations of corneal and lenticular opacities. The S you could remember strokes, which manifest in the brain and the heart. In the heart, it can be myocardial infarction, left ventricular hypertrophy, hypertrophic cardiomyopathy, fibrosis, or arrhythmias. So what can be a simple algorithm for diagnosis? The first step is measurement of alpha-Gal A activity in the leukocytes, which is the gold standard. You could also measure the enzyme in plasma or dried blood spot. The second step is you look for accumulated sphingolipid excretion in the urine. Now, this was initially done. Now, measurements in the plasma of its degradation product, lyso-Gb3, is used as a biomarker because it is more sensitive and specific, and it also correlates with disease severity. Now, tissue biopsies are rarely done nowadays. If you do it, then you can look for glycolipid deposits in the skin on the kidneys. And electron microscopy typically shows this zebra body. So you can see this lysosomal accumulation leading to this zebra skin-like appearance. And finally, the confirmatory test is the genetic testing for GLA gene, which is always necessary to identify the causative mutation because there are certain forms of therapies which are based on specific genetic mutations. The additional evaluation is to look for the additional organ involvement, such as the kidneys, the heart, the brain. Now, coming to the treatment options, there are two basic treatment options. One is the enzyme replacement therapy, and the other one is the chaperone treatment. The enzyme replacement is the form of two intravenous preparation, the alpha-galsidase the alpha and the beta-galsidase, which are both given intravenously. And the chaperone treatment is in form of an oral compound, migalastat. Now, just briefly about these therapies. So the current therapies which are used are the IV therapy, which is in the form of enzyme replacement, and migalastat, which is in chaperone therapy. Now, just a brief about the drawbacks. So when you give a recombinant enzyme in the body, there's always a risk of formation of anti-drug antibodies, and you also need a continuous venous access because this drug has to be given lifelong every 2 weeks. With the oral drug, these drawback is that it can only be used in certain amenable mutations, and we'll be discussing this further. So among the two options in the enzyme replacement therapy, there's been no difference in treatment efficacy between the two formulations. There's currently no consensus regarding the timing of commencement of therapy. However, it is best done if it is prior to the development of irreversible organ damage. And ERT has shown significant improvement in kidney functions, neuropathic pain, and some part of cardiac functions. However, there has been no reduction in the risk of stroke with enzyme replacement therapy. Now, just a word about the chaperone. What does chaperone mean? Chaperone is basically someone who looks after and supervises another group of people. So chemical chaperones are basically molecules that bind and stabilize the misfolded proteins in the endoplasmic reticulum. Thus, they help in the regular trafficking and they utilize the residual activity of the enzyme. So migalastat, when it is used as a chaperone, what it does is that it binds to the defective enzyme, which has some residual activity. It helps in the transportation of the enzyme to the lysosome, and then it helps in stabilizing the enzyme so that whatever defective enzyme the body is producing is utilized. Now, the only problem with this that this chaperone therapy can be used only in certain mutations of Fabry's disease, and that happens only in 30 to 50% of the cases. Currently, there are only 367 amenable mutations known. So for use of chaperone therapy, you need to know the genetic basis of Fabry's disease. Now, there are certain neurotherapies in development. The first of these is the novel enzyme replacement therapy in the form of pegylated enzyme replacement therapy. This novel pegylated formulation has better pharmacokinetic properties. It is less immunogenic, and it has an increased uptake, therefore more efficacy. The other one is gene therapy, which is in the form of either we introduce mRNA in the cell or we introduce the gene. Now, we all know that when an organism has, if suppose this blue is the defective gene, so what we do is that we introduce a vector into the cell which brings a correct gene, and then this corrected gene is incorporated in the genome, and this defective gene is knocked out. So this could be done by the infusion of systemic mRNA. This could be done by a vector gene administration where an adenovirus can be used as a vector. Or this could be done by transduction of gene in the harvested cell and then the subsequent administration of these cells via the hematopoietic stem cell transplantation. The obvious disadvantage is that since you're introducing a foreign matter, there's always a risk of generating antibodies to the viral vector or the new enzyme which is being generated. The third newer research is the availability of substrate reduction therapy, where basically the glycosylceramide synthase enzyme is inhibited by these two preparations, lucerastat and venglustat, and therefore this helps in the reduction of production of GB3 as such. So basically this is reducing the first step itself. So this is just a diagrammatic compilation of the therapies available for Fabry's disease. So going from below upwards, the mainstay of therapy is the enzyme replacement therapy in the form of egalsidase alpha and beta. The second therapy which can be used in specific genetic mutations is the chaperone therapy, where the chemical chaperone stabilizes the residual enzyme. The third therapy is the form of administration of exogenous mRNA via lipid nanoparticles. The fourth is a form of gene therapy where an adenovirus or the transfected cells can be infused into the host. And then is the substrate reduction therapy, where the basic enzyme is inhibited so that GB3 is produced less. So supportive care, since the disease cannot be completely cured, we have to monitor and look for other organ system involvement. The hypertension and supportive treatment has to be given for hypertension. For end-stage renal disease, of course, renal transplantation with continued ERT has to be given post-transplant. So these are the references, and thank you for your listening.
Very nice. I think you covered everything again in such a short period, around 12 to 13 minutes. Excellent. You've given all the organ features and more so the new developments in treatment. You've so nicely elaborated. I think that was very good. So thank you very much, Arushi.
Thank you, sir.
Thank you. Thank you. Let's take our fourth lecture now on an important neurocutaneous syndrome, which is tuberous sclerosis by Dr. Kasegaonkar. I request him to give us his insights. Dr. Kasegaonkar. You can share the screen now.
Yes, I'm sharing. Good evening. Thanks, Shripad, and thanks, Fine, for inviting me to teach tuberous sclerosis complex to the neurology PGs. So here is the outline of my talk. Firstly, I'll be talking a brief about history of tuberous sclerosis, then introduction, a brief about pathophysiology, major and minor features with diagnostic criteria of TSC, details of clinical features with specific reference to neurology, the investigations which need to be done, their frequency and neurology specific investigations, and I'll dwell upon the treatment options which will include both medical and surgical treatments. So this was described way back in 1880 by Bournville, who saw the brain gross structures and compared those tubers to potato, and he described them as sclerose tuberose. In 1908, Vogt came up with a classical triad of intractable epilepsy, mental retardation, and adenoma sebaceum to describe tuberous sclerosis. And this has been a formal training for all of us, including my training in my graduation and post-graduation, which makes us think that tuberous sclerosis is intractable disorder. It has got very poor prognosis, and it sort of gives a nihilistic attitude towards such patients that we come across. However, this classical triad of Vogt is seen only less than third of patients of tuberous sclerosis. That means large number of patients will have little better prognosis than what is described way back around 120 years ago. So to introduce, tuberous sclerosis complex is a genetic disorder which has got three important things to remember. So this is a disorder affecting cellular differentiation, proliferation, and migration in early development of the brain. Not only just the brain, all organs. So this leads to formation of various hematomatous lesions all across the body, which will be specifically affecting mainly brain, kidney, lungs, heart, and skin. So these are the five organs which we are supposed to remember. About epidemiology, the frequency of this particular disorder is relatively unknown. Actually, this is just a presumed incidence of 1 per 6,000 population, and the prevalence is is around 1 in 10,000. However, uh, because the patient's clinical phenotype is not seen in all patients, especially in early age, I personally think it is largely underdiagnosed condition, especially early on, because this classical adenoma, sebaceum, and epilepsy sometimes come little later. It will affect all races with a without any clear-cut predominance to particular race. It affects both sexes equally because it is autosomal dominant condition. So about pathophysiology, it's an autosomal dominant condition with high spontaneous mutation rate. So not all cases are run in family. A lot of them will have spontaneous mutation, which will present as a sporadic case in that particular generation. So in terms of gene, there are two types of genetic loci which are seen. One is TSC2, which was described first in 1993. It is coming from chromosome number 16, short arm of chromosome number 16, and TSC1 was described for long arm of chromosome number 9. So TSC2, which is much more common type, represents a protein called as tuberin. So it is a GTPase activate. It has got GTPase activating properties, and it has got a tumor suppressor properties. So it has got naturally high concentration in brain, heart, and kidneys, and that's the reason why any abnormality in this will cause much more severe affection of remaining these three particular organs. The TSC1 product is hamartine, which is also a tumor suppressor protein, and these two together, if they are abnormal, the patient will have a lot of hematomas all over the body. In most patients, there is also a peculiar phenomenon called as second hit phenomenon, wherein the normal allele of the pair of genes, it will have mutations. So there will be either inactivating event or there will be a complete mutation in the second allele, which will lead to various phenotypic variations, which are seen in various forms of tuberous sclerosis. Even you all may have seen TS, which has got different phenotypic presentation. So these are major and minor features of TSC. So to remember, for you to remember, there are 4 skin manifestations, 3 brain manifestations, and 1 each of heart, lung, kidney, and eye signs. So in the skin, adenoma sebaceum, ungual and periungual fibroma, hypomelanotic macules, that is Ashleigh macules, chagrin patch, these are the 4 skin manifestations, cortical tuber, subependymal nodule, and SEGA, that is subependymal giant astrocytoma, are the 3 neurological manifestations. And in remaining systems, we have cardiac rhabdomyoma, lymphangio, leiomyomatosis in the lungs, renal angiomyolipomas, and multiple renal retinal nodular hematomas are the major clinical features. Amongst minors, you have dental enamel issues, hematomatous rectal polyps, bone cysts. You can have cerebral white matter radial migration lines. If you have more than 3, that can be considered as a major sign. There can be some signs in the gingiva, that is gingival fibromas. You can have non-renal hematomas, retinal achromic patch, confetti lesions, and multiple renal cysts. So to conclude a case as a as a case of TSC, you need to have either 2 major features or 1 major with 2 minor features. And to say somebody as a possible TSC, we should have at least 1 major feature or 2 or more minor features. See, molecular genetic testing is usually useful in only cases which are where the diagnosis is unknown. We think it is tuberous sclerosis, but we are not sure, or we want to screen family members of an affected individual, especially if a kid is affected and the younger kid, we need to know whether he has TS or not. We should go ahead with genetic diagnosis. So what's about neurology of tuberous sclerosis complex? So you just need to remember three things. One is tubers, second is subependymal nodules, and third is subependymal giant astrocytoma. So these are the three things. I'm going to dwell into these three one by one. So let's talk about tubers. So tubers are mostly noted all across cerebrum. So they don't have a specific affection or affiliation for one particular lobe. You will find them all over the brain. You can also have small tubers in cerebellum, but they are usually microscopic. They are not very commonly seen on MRI examination. Very, very rarely we can have tubers in brainstem and spinal cord as well. Now, the fate of the patient depends on the number, size, and the location of the tumor. So, if somebody who is lucky, who has less tubers, who are not affected, which are not affecting any important or strategic areas of the brain, will survive with relatively normal life. But if somebody who has got lot of tubers, especially in the allocant areas of the brain, he or she will have a lot of neurological abnormalities in the form of global developmental delay, intractable epilepsy, gait abnormalities, cerebellar dysfunction, and so forth. Subependymal nodules, as the name suggests, will be seen along the ependym. So you will find them around lateral ventricles. They are either discrete or they are confluent to form a sort of firm, rounded hypertrophic tissue. Subependymal nodules you will find everywhere. However, they are most common in caudothalamic groove in the vicinity of foramen of Monro. So these are subependymal nodules. So around 5 to 10% of subependymal nodules will get converted, will get degenerated into a larger structure called as SIGAs, that is subependymal giant astrocytomas. Mind you, all SIGAs grow very slowly. So since they grow slowly, they remain compensated for very long. Since they are in ependymal region, if they are around foramen of Monro, they are going to compress foramen of Monro, and the patient develops slow hydrocephalus. So as I told you, they will remain compensated for very long, and the patient will suddenly will have a very huge hydrocephalus, sometimes even hydrocephaly. So the neurological presentations will depend, as I told you, depending on the load of the pathologic structures. So you can have, early on you can have West syndrome, later on there can be a Lennox-Gastaut syndrome. In relatively young elder children or in adults, you will have partial epilepsy, which is usually drug resistant. It is a bit difficult to treat. We must do prolonged video EEG because we want to detect specific syndromes related to these tubers like Lennox-Gastaut or West syndrome. We must capture and classify each patient's multiple seizure types, and also we must educate the patient's relatives about what are ictal events and what are non-ictal events after the video EEG. So what are other features apart from neurology? So in kidneys, we can have autosomal dominant polycystic kidney disease. We can have just simple renal cyst. And what is disabling is angiomyolipomas. That is something which will lead to ESRDs and early deaths. In the lungs, peculiarly, it is seen, lung involvement is seen in adult women who are generally 30 years or older. So they can have either multifocal micronodular pneumoastrocyte hyperplasia or MMPH, pulmonary cyst, or lymphangiomyomatosis. In the skin, as I told you, the skin manifestations are very classic. Angiofibroma, that is adenoma sebaceum, which is seen on the face, Ashleaf macules, which are hypomelanotic macules, which are seen all over body, especially on the back, periangual fibromas, and chagrin patch, which is slightly hyperpigmented, slightly orange colored large patch over the back. In the heart, they have rhabdomyoma, especially in infants. There can be early deaths as a result of rhabdomyomas. They will all regress as the age will progress. So these are the pictures of adenoma sebaceum, periangual fibroma, and Ashleaf macule. So what are the investigations we need to do? So obviously for brain we'll do MRI, for abdomen and heart we'll do the CT scans and ultrasound, and we'll do echo again for heart. Since the lesions are changing in nature, angiomyolipomas will grow, LAM will grow in chest, the tubers will grow, the SIGAs will develop. We need to keep on monitoring such patients with frequent investigations. So some people advocate we should be doing annual investigations of such patients, but then that practically becomes very expensive to do MR, CT, lots of ultrasounds and echoes each year or maybe 6 monthly. So in 2012, International Tuberous Sclerosis Consensus Conference recommended brain MRI to be done once in 1 to 3 years up to the age of 25 years, annual clinical assessment of renal functions and blood pressure, and if required, abdominal MRI and CT, echo every 1 to 3 years, especially to look for rhabdomyomas and if they are progressing or regressing, and HRCT every 5 to 10 years in asymptomatic females above 8 years to look for LAM, and every 2 to 3 years for patients with lung cysts. So we must keep on observing such patients with frequent investigation and not just go clinically, even if the patient is stable. So what are the investigations that we should be doing? Obviously, we'll be doing MRI brain. Why? Because this is superior to CT scan in detecting tumors. It will also help us pick up migrational abnormalities and vascular lesion. Obviously, FLAIR will be better because most of the lesions are periventricular. So FLAIR will obviously be better than T2. Subependymal nodules and SIGAs will classically enhance on contrast. However, they do not mean, if they are enhancing, doesn't mean they are growing. Sometimes they are enhancing and they'll still remain stable for years together. Angio sequences will be required in certain cases because aneurysms are also common in tuberous sclerosis complex. They'll be seen in around 3% cases of TSC. So if you find some lesion which is slight enlarging on serial scans, we'll be doing more frequent investigations, especially if somebody has developed SIGA or somebody has developed hydrocephalus, we'll be doing more frequent imaging in such patients. However, not all lesions will keep on growing. Most of the lesions will stabilize after some time and they will stop growing spontaneously after increasing in their size. So if they stop growing, the patient is stable, will not touch them, obviously, surgically. We must be doing EEG for a very low threshold, I would strongly recommend, because if we pick up subclinical seizures little early, the neurodevelopmental outcome will be much, much better. Now, these are the examples of MRI. You can see a T1 weighted post-contrast images showing tubers in the subependymal nodules. These are cells, and there is a large SIGA in the frontal lobe on T2 weighted images. So what are the treatment-based options? So the treatment is mTOR kinase inhibitors, that is sirolimus and its analogs. So sirolimus was originally available as immunosuppressant. It is still being used as immunosuppressant suppressant in Western countries. There are two analogs of sirolimus, that is everolimus and its prodrug temsirolimus are used in TSC. So everolimus is available as tablet or dispersible tablet, and in US it is been approved for patients with SIGA, patients with partial epilepsy, partial onset seizures after the age of 1 to 2 years. It is also been approved after EXIST-3 trial, which showed that it reduced the frequency of treatment-resistant seizures associated with TSC as compared to placebo. Also, it has been useful and it has been promoted in patients who are having new or growing SIGA. So SIGAs are actually known to reduce in size in more than 50% of the cases. So this is one excellent treatment and I have used it with quite a good effect in my patients. What are anti-epileptic drugs which we should be using? So the choice will obviously depend on the patient's age, type of epilepsy, patient's weight, patient's other involvement, other organ involvement, and its side effect profile. Obviously, vigabatrin, as we all know, Sabril is the first drug of choice in patients, children with TSC, especially with infantile spasm. We can also use topiramate, lamotrigine, valproate, ACTH, and steroids in individual or in combination based on the clinical situation. In 2020, this year, this new drug called as cannabidiol has been approved by US FDA for the patients with TSC of age 1 year and older. And they did a trial, phase 3 trial, which had enrollment of 221 patients, and of which 201 patients completed the study. And the dose of 25 milligram per kg per day achieved a greater seizure reduction as compared to placebo, which was close to 50%. About sodium channel blockers, carbamazepine, oxcarbazepine, and phenytoin should not be used in infants with infantile spasm, because they tend to worsen the infantile spasm. However, with older children and adults with partial seizure, partial epilepsy, these are wonderful drugs. They do very well on these medications. Surgery is usually palliative. It can be done for two purposes. One is to control epilepsy, in which is in the form of focal cortical resection or thermal abrasion. You can also do corpus callosotomy. We can consider VNS in certain select situation. And if the patient is having SIGA with progressive hydrocephalus, we may consider doing surgical debulking of SIGA, or we can proceed with a VP shunt as well. So to conclude, we must keep very high index of suspicion for cases of adenoma, for case who seems to have adenoma sebaceum on clinical examination. We must look for TSC, especially we must do frequent investigations in cases of proven TSC in the form of MRI and other investigations. We also should be doing a lot of cross consultation in the form of nephrology opinion and cardiology opinion and pulmonology opinion, because this is a multisystemic disorder. I thank you for the attention. Thanks, Shripad, once more.
Excellent. I think again this was very comprehensive, and may I again bring to your notice, Dr. Kasegaonkar also has put up a slide on a little bit of recent advances on particular area with this cannabinoid, and so have my other speakers done. So remember, even in lectures like these, bring up any new issue if it is there. It will add a mark or two in the short note that you are going to present to the examiners. Thank you. I think all lectures were excellent, and they were feast of information, and the amount of time and space in which all of you have covered is even more, worthy of praise. I personally used to think all these topics extremely difficult, but from the way you presented, you made them appear so easy and fluent. Thank you very much, all of you. Really, very appreciated. Thank you, Dr. Kaur, Dr. and Dr. Lingappa.